Hello, my name is Quentin Broussard, and I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing nutrition and home care. The reason why we are discussing nutrition and home care today is because many patients requiring nutrition support may be in the outpatient or ambulatory care setting versus the inpatient setting, which we have talked about extensively throughout this course. Outpatient nutrition support management is very different compared to inpatient nutrition support management and has its own specific challenges related to it, as patients are not followed up as routinely or daily as they are in the inpatient setting. Our objectives for today will be to describe advantages and complications of home nutrition support, to identify eligibility criteria to receive home enteral nutrition and home parenteral nutrition, to discuss discharge planning of patients going home on home enteral nutrition or home parenteral nutrition, and to develop monitoring plans for patients on home nutrition support, including both enteral and parenteral nutrition. In regards to epidemiology of nutrition and home care, about 3.3 million Medicare beneficiaries receive home health care annually. And the first home discharge on parenteral nutrition, or also known as home parenteral nutrition or HPN, was in 1968. So you see here that in regards to home parenteral nutrition, this is actually a relatively new specialized population, as it's just over 51 years old. About 56,000 people receive home parenteral nutrition annually, and about 350,000 people receive home enteral nutrition annually. So that you see here that there's a significant population here that receives home nutrition support, either it being home parenteral nutrition or home enteral nutrition. CMS, or the Centers for Medicare and Medicaid Services, reported almost $600 million in allowable charges for home parenteral nutrition and home enteral nutrition. So not only is home nutrition support important just for patients, it also, as you see, contributes a significant amount within the economy and within the amount that CMS actually reimburses for patients who have Medicare or Medicaid. Some advantages of home nutrition support is that it's cost-effective when compared to daily hospital or skilled nursing facility cost. If you think about it, if the only reason that a patient is in a hospital is because they are receiving some kind of nutrition support, such as enteral nutrition or tube feeding or parenteral nutrition, they may be an eligible candidate for home nutrition support. And essentially, we want to try to get these patients out of the hospital as quick as possible, not only for their own health benefit, but from the benefit that they will essentially be saving a lot of money by going home. And if you have the right variables in place in the home setting where that patient lives, you can essentially ship them off home on nutrition support. And obviously it'd be more cost effective just paying for that nutrition support modality versus paying for that nutrition support modality in a hospital, where your hospital stay can amount to over thousands of dollars per day. And in regards to an acute care bed, that can be within the single digit thousands. For an intensive care unit bed, that can be over $10,000 a day. So if you basically can get these patients home once they are stable, and the only thing that is holding them back from going home is basically a nutrition support modality such as tube feeding or parenteral nutrition, if you meet the criteria, it's very cost beneficial to get them home. So this obviously, home nutrition support can avoid prolonged hospital stays as a result of what we just talked about, skilled nursing facility admissions, or even repeated hospitalizations. But remember that this therapy in regards to nutrition support still needs to be monitored very carefully. And whenever patients go home on home parenteral nutrition or home enteral nutrition, they are still monitored. In addition, home nutrition support also allows the patient and family members to take an active role in nutrition therapy. Sometimes the patient and the family members may even be trained on how to administer enteral nutrition or parenteral nutrition, either to themselves or to their family members, because they may not necessarily be monitored every single day depending on what the circumstances are. Say if they are at a skilled nursing facility, they may be monitored every day, or if they're at a rehab facility or some kind of nursing home. But if they're at home by themselves, they may be monitored potentially once a week, or even for more extended periods, depending on how stable the patient is and how comfortable the nutrition support team and the healthcare team is in regards to that individual patient and that patient's situation. In regards to indications for home enteral nutrition and home parenteral nutrition, home enteral nutrition, or HEN, has its own indications. So basically these are more or less the same indications that you saw for enteral nutrition within the inpatient setting. These are just some of the common ones that we see on the outpatient setting or the ambulatory care setting. So mechanical GI tract dysfunction, such that you can still feed part of the GI tract. Sometimes some motility disorders where we can still feed enteral nutrition. Some malabsorptive syndromes where we can still give enteral nutrition and they can essentially still absorb it in some parts of their GI tract. Some head, neck, and digestive malignancies or cancers, as we talked about briefly with nutrition and oncology. Dysphagia or swallowing disorders is a reason why you can get essentially enteral nutrition. Chronic pancreatitis. GI fistula. So remember, a fistula is just a little bit of a disconnection or a little hole potentially that's within the GI tract that causes a leakage. In those cases, we'll want to feed distal or beyond that GI fistula so that none of the nutrition actually leaks out. If you have a bowel obstruction, depending on the severity of the bowel obstruction, you can feed distal to that obstruction depending on how big it is, and if that you can pass a tube distally past that area, or if your patient has a PEG tube or a PEG tube. Remember, percutaneous endoscopic gastrostomy or percutaneous endoscopic jejunostomy, which a lot of patients who are in the home setting will actually be on versus nasogastric tube or nasojejunal tube. Acute and progressive neurological conditions such as stroke, where patients may not be able to feed themselves normally. Hyperemesis gravidum, which is related to pregnancy, and essentially pregnant patients having essentially this vomiting disorder. Failure to thrive, which essentially means that a patient is not able to potentially do their activities of daily living on their own. In addition, a specialized population that may receive home enteral nutrition is inborn errors of metabolism. And these are typically errors of metabolism where patients may have altered metabolism of things such as ammonia. And altered metabolism of ammonia can obviously limit you in regards to your actual intake that you can take in, and is a very, very unique population. Particularly, you see more inborn errors of metabolism with pediatrics versus adults. For home parenteral nutrition, indications are HPN indications. So that is whenever we see some kind of obviously GI failure or intestinal failure or dysfunction. A large portion of patients that get home parenteral nutrition have short bowel syndrome or SBS, like we talked about previously. Also, you see malabsorptive disorders, acute or chronic bowel obstruction, depending on that severity of that obstruction. Like we talked about earlier, bowel obstruction can be an indication for home enteral or home parenteral nutrition. Crohn's disease, radiation enteritis, which you see with radiation therapy related to oncology patients and cancer patients who receive radiation as part of their therapy to basically minimize the cancer. Intestinal ischemia might be a reason for home parenteral nutrition. Say if a patient had low blood flow to their intestines. One common area where we see this in is patients who have sepsis within the hospital setting, and they develop ischemic bowel within the inpatient setting, and essentially that bowel is now potentially not functional or even necrosed and has potentially been removed. In that case, you might need a patient to be on parenteral nutrition long term. Intestinal or pancreatic fistulas, depending on how much fistula output there actually is, as well as chronic pancreatitis. And the pancreatitis of chronic nature, the severity will dictate whether you are on home parenteral nutrition or enteral nutrition, depending on your severity and how well the patient can tolerate food. So whenever a patient gets discharged from the hospital, usually these are, in regards to home care nutrition or home parenteral or home enteral nutrition, one of the things that we want to look out for first is this patient actually going to need long-term nutrition therapy at home or on the outpatient setting. And usually you have to qualify for this using typically Medicare or Medicaid's specialized criteria for eligibility, which a lot of other insurances will also use and base their criteria off of Medicare and Medicaid or CMS. So we want to obtain the required diagnostic tests and procedures to demonstrate medical need for home nutrition support and verify insurance coverage. That is step one. Then we want to make sure that we have some kind of access to feeding, whether enteral nutrition or parenteral nutrition. So a lot of times with enteral nutrition, like we said before, that's going to be a PEG tube or a PEDG tube. For parenteral nutrition, usually that will be some sort of central line. It's important to explain to patients the benefits and risk of home nutrition support, that they are aware of what the benefits and the risk are in the event that they need to potentially go home on home nutrition support. One of the most important factors in discharge planning is to assess the patient and or caregiver's ability to perform the tasks that are related to home nutrition support. If a patient or caregiver you think is not going to be able to take care of the patient very well, so if the patient's not able to take care of themselves very well, or if the caregiver is not, very skilled in being able to perform normal tasks, this might not be necessarily the best patient for you to discharge on home nutrition support. So actually these patients and caregivers or caregivers will actually receive training typically prior to discharge or just upon discharge from a home infusion company or a company that does home enteral nutrition. And they will basically provide training to the patients and to the caregivers in regards to how to manage the enteral and parenteral nutrition associated tasks. If you don't think that that patient and or caregiver is able to perform those tasks very well, this patient may not be able to be a great candidate for home nutrition support. That's very important, as you see that there will be many complications that can result from home nutrition support that we'll talk about in a moment. And then you also additionally want to determine the home infusion or care providers and the prescribers of home nutrition support. So essentially this is a step in transitions of care. You're transitioning the patient from the hospital or inpatient setting to the home setting. So you want to make sure all of this stuff is set up prior to discharge of your patient. In regards for reimbursement, for enteral nutrition specifically, there are a long list of home enteral nutrition eligibility criteria that have to be met. The major one that I want you to know is that that a patient will have to be predicted to require enteral nutrition for at least 3 months. That's very important and is the same as the home parenteral nutrition requirement. It's usually a condition which we consider there is permanent non-function or permanent disease of the GI tract, such that the patient will actually require enteral nutrition. We might additionally require that they see that adequate nutrition is not possible via oral means alone. And they have to have a diagnosis via ICD-10 code pertinent for the need for enteral nutrition. So basically, they need to have basically one of the diagnoses, essentially, that we listed previously. You may also see other things that are required for documentation, such as motility studies, swallowing studies, radiographic evidence of a small bowel obstruction, for example, operative notes if they did some type of surgery that resulted in the patient needing enteral nutrition support, justification for specialty enteral nutrition formulas, energy prescription expressed in kilocalories per kilo daily, obviously have a feeding tube, and if a feeding pump is requested, evidence that gravity feeding causes reflux, aspiration, severe diarrhea, or dumping syndrome. And what a feeding pump essentially is, another term that we use for feeding pump is kangaroo pump. Is it just essentially the pump that patients use to deliver their enteral nutrition? Patients can also feed by gravity feeding, which essentially means that they basically hang the enteral nutrition and let gravity basically determine the flow rate, because remember, enteral nutrition is not just given continuously, but can also be given intermittently. So it can be given as bolus doses in some cases, depending on your patient's tolerability. In regards to parenteral nutrition reimbursement elements, all patients who are going home on HPN or parenteral nutrition in the home setting, conditions that require parenteral nutrition for at least 3 months. So essentially, it basically means that this has to be more or less what they consider a permanent condition. You also have to have an ICD-10 code pertinent to the need for parenteral nutrition. You have to have a condition severe enough where weight and strength cannot be maintained by oral intake or enteral nutrition alone. We also have to have a weight history on the patient, and a serum albumin within 1 week of home PN. And that is just a requirement for all patients. Now, in regards to disease-specific criteria, you actually see them here. I'm not going to necessarily ask you about any of these disease-specific criteria, but depending on the type of disease state that you have, will dictate the actual criteria that you need. So some of these disease-specific criteria or diseases may require radiographic reports, so scans showing that there's some kind of abnormality. You might have to show a pathology report for some cases, indications for bowel rest. You might have to show that there is a contraindication to enteral nutrition. You might have to have evidence that you have basically gone through other pharmacological approaches. So essentially with HEN and HPN, home enteral nutrition and home parenteral nutrition, it's almost like you're getting a prior authorization whenever we think as pharmacists from the pharmacy side. They have to meet the criteria, and if they don't, they need supporting documentation. And if they don't have that appropriate supporting documentation, they may not qualify. As we talked about, motility studies, radiographic reports, operative reports, contraindications are very important here in regards to documentation for home parenteral nutrition and reimbursement purposes. This is just the comprehensive list blown up a little bit bigger so that you can see it a little bit clearer. In regards to nutrition requirements, again, this is based off of our typical nutrition calorie assessment tools. Indirect calorimetry is the gold standard, as always, but remember that's limited in regards to its availability. So in a lot of cases, we'll use either predictive equations or weight-based equations. And one predictive equation that you can potentially use in some home patients is the Harris-Benedict equation, because it is based off of healthy patients. But again, that is dependent on your patient's disease state and what they actually have, and if Harris-Benedict is actually applicable to that patient population. In regards to monitoring, you have to keep in the back of your mind for a home nutrition support patient that labs still need to be obtained on a regular schedule, even though the obtaining of these labs will probably be at a greater interval compared to what you saw in the inpatient or hospital setting. So remember, inpatient or in the hospital setting, we got labs daily. Here, labs may be taken at a greater length of time apart. The labs that you need to get on a regular schedule are your basic metabolic panel, or BMP. So remember, that is your sodium, your potassium, your chloride, your bicarb, your BUN, serum creatinine, and glucose. You also need to get hepatic function, or LFTs, regularly, your albumin and prealbumin regularly, CBC, which includes white blood cell count, hemoglobin and platelet count, and serum magnesium and serum phosphorus. One common thing that is usually missed is that serum magnesium and serum phosphorus are not included in most traditional BMPs or basic metabolic panels. So these have to be actually ordered separately, and is an easy intervention that you as a pharmacist can make in regards to monitoring your nutrition support therapy. Upon discharge, typically we obtain labs weekly for the first 4 weeks after a patient gets discharged, or until they are stable. And usually stable means that we have to have at least multiple labs or sets of labs to determine if a patient is stable. Once the patient is stable, labs can be obtained once a month, or even on a less frequent schedule, depending on the patient's situation and plan of care. Say if your patient is living relatively rurally and doesn't have access to home health, or essentially someone who can come and draw the labs routinely, those are cases where a less frequent schedule may be appropriate. But keep in mind that if you are monitoring labs once a week, or once a month, or even along the lines of even once every 2 months, you have to be very careful, because any adjustments you make with your home enteral nutrition or your home parenteral nutrition regimens will be amplified. So remember how we basically have been making changes based on day by day. Now the changes that you make, you have to basically predict what is going to be your potential risk and benefit of increasing or decreasing, for example, electrolyte in the parenteral nutrition formula, for example. Because you're not going to check it for another 7 days. So you can't be very aggressive in terms of managing your actual formulas. You have to be very conservative with these patients, because if you are too aggressive, that may actually cause the patient harm in the end. Some labs that need to be obtained every 3 to 12 months include a phospholipid fatty acid profile, which is also known as a triene tetraene ratio. This is just a ratio that is used to determine if a patient has essential fatty acid deficiency. Remember, essential fatty acid deficiency is a complication from not giving your essential fatty acids within due time. So usually this will be okay, but if a patient is not getting enough fat or essential fatty acids in their diet that you're giving them, that can be a concern. You might also take vitamin serum concentrations every 3 to 12 months, trace element serum concentrations, as well as iron indices, including iron, ferritin, transferrin saturation, and total iron binding capacity, or TIBC. These are, again, labs that you take every 3 to 12 months, so that these labs are labs that you do not have to take very often. In regards to complications, remember how we talked earlier about the fact that the patients and their caregivers have to at least be cognizant and able to be educated regarding your patient? Well, that's because complications can obviously occur. And if complications occur, usually those patients or caregivers will need to act. And they will either need to act themselves, or they will need to act with the assistance of their home care company. And usually the home care companies will have someone come in, at least at the very beginning of when the patient gets home nutrition support. However, if that person is not coming in regularly, or if a patient has basically kind of graduated more or less to the point where they don't need to have someone come in routinely, then they will need to be able to report these complications themselves. In regards to complications that can happen are mechanical in nature, so those can include occlusion of a tube or catheter, leakage of a catheter or tube, malposition of a catheter or tube, like we've talked about with enteral and parenteral nutrition, and accidental device removal. And that can obviously be complicated because sometimes patients might obviously not be able to place those access for enteral and parenteral nutrition back into the specific area. They might actually need to get help to actually put the access back in. Obviously, anytime that you go on nutrition support, there's always infection risk, and those infection risks can be related to the access device. So remember how we talked about parenteral nutrition. If you have a line in, particularly a central line, those lines are always prone to infection risk. And as a result, the patient will actually need to do line care daily so that that line is kept clean and essentially as sterile as possible. Exit site infections can also be a problem. So say if you have basically an exit side of a PEG tube, for example. If you're not taking care and keeping clean your PEG tube, for example, then in that case, that might also be reason why a patient eventually develops, for example, a skin soft tissue infection. And obviously, any skin that you have around that access device or exit site can also become infected as well, and you can develop a skin soft tissue infection, which can then get worse. In terms of metabolic side effects, our typical fluid and electrolyte abnormalities are always prone to happen. And blood glucose abnormalities are also prone to happen as well, which you can potentially treat with insulin if you have hyperglycemia. Or if you have hypoglycemia, that can also be a potential problem, particularly if you have insulin in the PN bag. And in those cases, you'll usually want to stop the PN bag and treat the hypoglycemia with your standard hypoglycemia treatments of basically intaking sugar in some form or fashion. In regards to patients who are on home nutrition support, we always want to make sure that we maximize preventing them from getting hospitalized again. And obviously, complications with home nutrition support can happen because this is a very specialized therapy. And remember that nutrition support, in a way, is almost like chemotherapy in a sense because you have multiple ingredients and potentials for instability. And complications can result as a result of inadequate training. So if you don't have a person who is trained adequately, or if you have a person who maybe does not grasp the training as well, that can be a reason why a patient might have one of the complications we mentioned before. Patient and caregiver non-adherence. If the patient and caregiver are not going to be adherent to the therapy, that's going to be reason for a complication. If there's a prescription error, and that's usually where we come in as pharmacists and healthcare providers, is making sure that there are no prescription errors at all. And this can be even along the lines of the infusion time for patients. Typically, we've been basically giving nutrition support over 24 hours within the course of this class. Well, in the home care setting, you have patients who receive nutrition support sometimes over shorter periods of time, such as 20 hours, 16 hours, sometimes 12 hours, or intermittently. And as a result, if that infusion time is not properly communicated to them, or if you essentially miss the infusion time on the prescription, even though all your components are right, that can cause its own complications. For example, if you infuse home PN over a shorter period of time than the patient was used to getting, that can cause adverse effects such as hyperglycemia, especially whenever you give dextrose within a shortened period of time. If a healthcare worker makes an error, similar to prescription error, but in regards to healthcare error, if they do not put the tube or the catheter in the right place, that can obviously be reason for an increase in risk of complications. Or if your equipment fails. Remember, technology is flawed. And if you have basically a pump or part of your equipment that fails or is faulty, that can be a reason why a patient might have to come back in. say if their pump is not delivering properly, or if their pump somehow results in the patient's catheter or tube becoming occluded, that can be a problem for a patient, and we don't want that to happen. One company that does provide home infusion support is CVS Quorum. This is just one company that provides home infusion in the home care setting. I have their website listed here. If you want to go to the website to take a look and see what they have, they actually provide a lot of different educational materials to patients on this website, which can be beneficial to patients, in addition to the typical education materials they always provide patients. But they also kind of list out other home care services that they provide. This is just one example of a home infusion company. I am not paid by CVS Quorum, and I'm not affiliated with CVS or Quorum, but they do provide great educational materials for patients who are needing some kind of home infusion care, whether that is nutrition support, enteral nutrition, parenteral nutrition, or even other IV medications such as antibiotics, or specialty medications like medications for multiple sclerosis, for example. Here are the reference for this talk. And if you have any questions regarding nutrition and home care, please let me know. Thank you and have a great day.